Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
You don't fix a living, pressurized, bending cylinder the way you'd, patch a hole in drywall.
Right. Yeah, definitely not.
Yet for decades, that was basically the prevailing approach to incisional hernias. You'd find a defect, you'd nail a piece of mesh over it, and you just call it a day.
Which is wild when you think about it. The human abdomen is this dynamic biomechanical engine.
Exactly.
And if you approach a reconstruction without, respecting the vectors of force or tissue elasticity or intra-abdominal pressure.
You're almost guaranteeing a recurrence.
Basically, yeah, 100%.
Which is exactly why today's deep dive is specially tailored for you, our listeners who are surgeons and medical doctors, looking to really refine or just refresh your understanding of complex abdominal wall reconstruction.
It's a complex topic, but so crucial.
It really is.
Yeah.
And because we are getting so deep into clinical strategy today, I do need to clearly state our mandatory disclaimer. This content is for reference only. Please ensure you follow local guidelines in your clinical practice.
Yeah, that is an essential baseline for literally everything we're about to discuss today.
Totally. So our specific target today is the standard open midline incisional hernia repair. And we're really focusing on the retromuscular or the Rives Stoppa plane.
Right, the gold standard.
Yeah. And our mission here is to shift the mindset from viewing this as just a single, operation to treating it as a structured, multi-phase sequence of strategic decisions.
Because that's what it really is. It's biomechanical engineering.
Okay, let's unpack this. Because to do that, we actually have to start before the patient even enters the OR, right?
Oh, absolutely. The success or failure of a complex reconstruction is usually cemented right there in the preoperative clinic.
Right.
We have to evaluate the hernia not just as a physical gap, but as a systemic physiological derangement.
And when we talk about evaluating that hernia, the critical metric that the operative textbooks really hammer on isn't just the two-dimensional size of the defect. It's this concept of loss of domain.
Yeah, loss of domain is a big one.
And for our listeners evaluating these patients, we aren't just looking at organs sitting outside the cavity. We are calculating volumetric thresholds on a CT scan.
Right, exactly. When the volume of the hernia sac exceeds, say, 20 to 25% of the total abdominal cavity volume, you are crossing a very dangerous physiological line.
Because the pathophysiology there is just fascinating.
Right.
And terrifying.
It really is terrifying. Because the abdominal cavity has essentially contracted over time. The organs have lost their right of residence, so to speak.
Right, they don't fit anymore.
Exactly. So if you attempt a forced primary closure, and you just shove a massive volume of viscera back into a contracted space, the sudden spike in intra-abdominal pressure alters everything.
Because you push the diaphragm cephalid, right?
Yes, you push it up, which severely restricts pulmonary excursion. That can lead straight to respiratory failure.
Oh, wow.
And you're also compressing the inferior vena cava, so that tanks your venous return, it tanks cardiac output. You are actively inducing abdominal compartment syndrome.
Right, which makes it a critical spatial physics problem. And I guess that's why the preoperative CT scan is completely non-negotiable.
Totally non-negotiable.
But let me ask you, does the CT scan actually change the physical approach, or is it just about mental preparation for the surgeon?
Oh, no, it directly dictates the strategy. It's your architectural schematic. When you're looking at that scan, you are measuring the interrectus distance in millimeters.
Right.
You're evaluating the width and the quality of the rectus abdominis muscles. You're looking for atrophied muscle bellies that tell you right away that a standard primary closure is completely off the table.
Right. So you already know you need advanced component separation before you even scrub in.
Exactly. And the CT also reveals the sins of the past.
The gold mesh.
Yeah. You can identify previously placed mesh that's maybe curled up or formed a dense scar plate. It tells you exactly where your entry point should be.
To avoid the worst adhesions.
Precisely. But, beyond the imaging, the patient's modifiable risk factors just have to be aggressively optimized.
Right, because, if you perform a beautiful, technically flawless Rives Stoppa repair on a patient with an A1C of 9.0.
Who's actively smoking a pack a day.
Exactly. You are actively setting that repair up for failure.
Yeah, nicotine causes microvascular vasoconstriction. It just devastates the perfusion that you desperately need for fascial healing.
And the guidelines are super strict on this, aren't they?
Very strict. You need documented glycemic control. You need mandatory smoking cessation, ideally with biochemical confirmation.
Wow. biochemical confirmation.
Yeah, you have to be sure. And you have to address prehabilitation, like optimizing nutrition, maybe weight loss protocols. A surgeon's greatest skill is often the discipline to just delay the surgery.
Wait, really? Just telling the patient no, not yet.
Yes. You need the physiological environment to be as pristine as possible before you subject the tissue to the trauma of reconstruction.
That makes total sense.
Mm-hmm.
So, all right, the blueprint is drawn, the volumetric math checks out, physiology is optimized. Yeah. Now we transition from the clinic into the OR. The fun part, right? We're entering what the textbooks describe as the most hazardous phase of the procedure, the entry and adhesiolysis.
Yeah, and the setup really sets the tone here. You need the patient supine with a wide prep. I mean, nipples to mid-thighs.
Flank to flank.
Exactly, because you expose the entire previous scar to plan for a possible extension.
And as you make that incision, preserving the vascularity of the skin envelope is just paramount. You're dealing with the angiosomes of the abdominal wall.
Right. If you arbitrarily excise too much tissue or you undermine the skin flaps unnecessarily, you destroy those perforating vessels.
And then you might fix the hernia, but you'll be left with a massive necrotic skin wound overlying your repair.
Which is a disaster.
Yeah.
So that brings us to the actual safe entry. You want to enter the hernia sac centrally or wherever that CT scan indicated there's the least likelihood of adherent bowel.
And the sources heavily emphasize sharp dissection here.
Yes, very much so.
There's this strict warning across all the literature to avoid blind diathermy. Because I guess the thermal spread from electrocautery on friable bowel.
Oh, it's a recipe for a delayed, unrecognized enterotomy.
I always think of it like untangling a massive knot of delicate cables. You know, like one wrong pull or one wrong move, and you cause a total system failure. You absolutely have to avoid blunt traction on friable bowel.
That's a great analogy. And what's fascinating here is the psychological discipline required during this phase.
Yeah.
Adhesiolysis isn't just a technical skill, it's a profound exercise in spatial awareness and patience.
Because it's a mess in there.
Right. You have to constantly reassess your orientation. You're asking yourself, where is the true midline? Where are the costal margins at this exact moment?
Right.
You're relying heavily on tactile feedback, feeling the difference between dense avascular scar tissue and the actual serosa of a bowel loop.
And you have to work some areas of known, easy separation toward the complex stuff, letting the tension and the sharp blade do the work.
Exactly. But we do have to talk about the contingency.
The worst case scenario.
Right. What happens when, despite meticulous technique, you get a serosal tear or a full thickness enterotomy?
Well, the entire flight plan changes immediately, right?
Instantly. You must address the bowel injury first. Close it, irrigate the field thoroughly, but the massive implication is how it alters your mesh strategy.
Because the field just went from clean to contaminated.
Exactly. And your standard macroporous synthetic mesh, like uncoated polypropylene, suddenly becomes a massive liability.
Because of the pore size, right?
Yeah, the pathophysiology comes down to pore size. Macroporous messes usually have pores larger than 75 microns, which allows macrophages to enter and clear bacteria.
Okay.
But if the bacterial load from an enterotomy is too high, the biofilm outpaces the immune response.
So the standard protocol forces a huge pivot.
A huge pivot. You might have to abandon the synthetic mesh entirely.
And use, like, a biologic mesh?
Yeah, a biologic mesh or a slowly absorbable biosynthetic mesh. Or in severe cases of gross contamination, you abandon the definitive repair entirely.
You just close the skin.
Close the skin, maybe place a vac, and stage the procedure for another day. It's drastic, but essential to prevent a catastrophic mesh infection.
Wow. Okay, so assuming we successfully navigate that minefield, the bowel is safely reduced without injury, we finally have a clear view of the fascial defect.
Right.
Now the procedure shifts from clearing hazards to architectural reconstruction. We're engineering the space.
And we start that by accurately measuring the defect under normal resting tension, so the transverse width and the craniocaudal length.
Because the primary goal, the holy grail here, is to achieve a primary midline fascial closure under acceptable tension.
Exactly, restoring the linea alba.
Right. And to achieve that, we utilize the Rives Stoppa technique to create that retromuscular pocket.
Yeah, you start by incising the anterior rectus sheath, just medial to the edge on both sides of the defect. That gets you into the retrorectus space.
But once you're in there, you elevate the rectus abdominis muscles off the posterior rectus sheath.
Right, which is a naturally highly vascularized plane.
So you dissect cranially up toward the costal margins. and caudally down to the space of retzius, because you need at least a 5-centimeter overlap, right?
At least 5 centimeters beyond the defect in all directions. And you have to be incredibly mindful of the epigastric vessels running within this plane.
Because injuring those compromises the blood supply to the very rectus muscle you're trying to save.
Exactly.
So what does this all mean if the tension is just too excessive to close? Like, you try to bring the edges together and the guitar string tight.
Yeah, if it's too tight, the sutures will just rip right through the tissue. So this is where we climb the escalation ladder.
Okay.
If the retromuscular dissection alone doesn't give you adequate medial advancement, we must release tension laterally.
Right.
The workhorse for this, in complex cases, is the posterior component separation, specifically the transversus abdominis release, or TAR.
The TAR. The anatomy of the TAR is so complex, but elegant. You are essentially unhinging the posterior layer to borrow tissue from the flanks.
That's a perfect way to describe it. You incise the posterior lamella of the internal oblique aponeurosis, which exposes the underlying transversus abdominis muscle.
And the critical anatomical landmarks there are the neurovascular bundles, right?
Huge point, yes. The intercostal nerves, specifically T7 through T12, run right in that transversus abdominis plane and supply the rectus muscle.
So when you perform a TAR, you have to stay lateral to the linea semilunaris to avoid denervating the rectus.
If you cut those nerves, the rectus muscle will permanently atrophy. Your beautiful repair will just bulge and fail over time.
Which would be tragic.
Yeah.
And I know surgeons debate the approach, like whether to do a top-down TAR or a bottom-up approach.
Yeah, top down near the costal margin where the fibers are distinct, or bottom up from the space of Bogros. Either way, dividing that muscle allows massive medial advancement.
It fundamentally alters the geometry of the abdominal wall.
Yeah.
And for those extreme cases of loss of domain we talked about, specialist centers will even use botulinum toxin, right?
Yeah, Botox injections into the lateral abdominal musculature pre-op.
That is wild.
It induces a temporary flaccid paralysis. It lets the muscle stretch and lengthen over a period of weeks before the surgery.
And they might even combine that with preoperative progressive pneumoperitoneum, like slowly pumping air into the cavity to stretch the tissues.
Yeah, to acclimate the diaphragm to the increased volume. It is biomechanical engineering at its finest.
It really is.
Yeah.
Right. So the space is prepared, the tension has been managed. Now we move to the sandwich structure.
The fun part.
Right. How do we ensure this reinforcement holds without causing internal damage? We move to the specific mechanics of layering the closure.
And that construction must happen in precise layers. The absolute first priority before any mesh enters the surgical field is closing the posterior layer.
Bringing together the posterior rectus sheath and the peritoneum.
Exactly.
And the texts mandate a continuous, slowly observable suture for this, like a 0 PDS, to create a vital, watertight barrier between the viscera and the synthetic mesh.
Yes, because if you leave gaps in that posterior layer and you expose synthetic mesh directly to the bowel wall,
the inflammatory response causes the bowel to densely adhere to the mat.
right, and over time the mesh will erode right through the serosa and mucosa. You get an enterocutaneous fistula.
Which is one of the most devastating complications in general surgery.
Absolutely. The posterior barrier must be immaculate.
Right. So once that barrier is secure, we introduce the mesh. For clean cases, we're talking a large, pore, lightweight, synthetic polypropylene or polyester.
Yeah, exactly. The structural properties of the mesh dictate the body's inflammatory response.
Okay.
Lightweight macroporous meshes minimize that foreign body reaction. They allow for rapid fibrovascular ingrowth. You get a flexible, integrated scar plate instead of a rigid block.
So you cut it for that 5-centimeter overlap, you round the corners to prevent folding, and lay it flat in the retromuscular pocket. And this is key, with minimal to absolutely zero fixation.
Yeah, the older literature hammered heavy fixation, sutures, titanium tacks.
Right.
But modern mechanics show that's a recipe for chronic pain and nerve entrapment. By leaving it unfixed in the Rives Stoppa plane, you're trusting Pascal's principle.
Right, because the mesh is sandwiched. When the patient bears down or coughs, the intra-abdominal pressure pushes the posterior layer up against the mesh, trapping it against the rectus muscle.
It's a sublay under pressure. The body's own biomechanics hold it in place. Heavy fixation is basically obsolete in this plane.
That is so cool. Now here's where it gets really interesting. The anterior closure, bringing the medial edges of the anterior rectus sheath together.
The final structural barrier.
Yeah, and the mathematical technique here is wild. It's the small bites technique, using a suture length to wound length ratio of 4:1.
The 4.1 ratio is a fundamental law of modern fascial closure. You take bites of fascia that are about 5 to 8 millimeters from the cut edge, and you advance your needle only about 5 millimeters at a time.
And the physics behind this are brilliant. Because when the abdominal wall violently stretches during a cough, if you use the old method of massive, widely spaced bites.
You're using a short total length of suture.
Right. And it has no give.
Yep.
So it acts exactly like a wire cheese slicer, ripping right through the fascia.
The cheese wire effect. That's exactly what causes early fascial dehiscence.
But with the small bites technique, you pack a massive amount of suture material into a small space. It acts like a coiled spring.
Exactly. It distributes the lateral tension evenly across dozens of microfixation points.
So the wound dynamically stretches and recoils. It's just elegant, mathematically sound engineering.
And it connects perfectly to the core philosophy here. You aren't just plugging a hole, you're restoring a functional midline abdominal wall with the appropriate vectors of force.
The internal structure is completely rebuilt, the mesh is sandwiched, the linea alba is restored, so we move to our final phase, sealing the deal and post-op realities.
Because how you manage the superficial layers in recovery dictates whether that beautiful internal reconstruction actually survives.
Right, we have to talk about subcutaneous management and the danger of dead space.
Dead space is the primary enemy of superficial wound healing.
Because if you heavily undermine the subcutaneous tissue, you've created a massive cavern.
And the body's response to an empty cavern is to fill it with serous of fluid. You get a seroma.
And a tense seroma is a prime breeding ground for bacteria, leading directly to a surgical site infection, or SSI.
Not to mention, aggressive undermining cuts off those perforating vessels we talked about, causing skin flap necrosis.
So the rule is judicious dissection.
Only elevate the skin flaps exactly as much as necessary. And if you do have significant dead space, particularly in an obese patient, you often have to place closed suction drains.
To evacuate the fluid. The literature also heavily advocates for closed incision negative pressure wound therapy, right? Wound vacs.
Yes, applied directly over the sutured skin incision in high-risk patients.
How does that help?
Well, it acts as a physical splint, offloading lateral tension. It aggressively clears superficial edema. The data clearly shows it drastically reduces SSIs and dehiscence.
Wow. And then post-operatively, you're looking at immediate analgesia, early mobilization for DVT prophylaxis, and abdominal binders.
Yeah, binders are great for proprioceptive comfort. But as the surgeon, your vigilance shifts to identifying complications early.
Like superficial SSIs.
Right. Those can often be managed with oral antibiotics or opening a small portion of the skin. But seromas and hematomas require a very disciplined, conservative approach.
Meaning you don't stick a needle in it.
You must resist that urge. Aspirating a sterile seroma introduces skin flora into that fluid. You turn a benign collection into a raging infection.
And if bacteria migrate down to that synthetic mesh,
you're facing a catastrophic deep mesh infection, which might mean prolonged hospitalizations, IV antibiotics, or completely explanting, surgically removing the mesh you just spent 6 hours engineering into place.
Oh, that is devastating. And long-term recurrence usually traces back to a failure in one of these core principles, right? Like inadequate overlap or high tension.
Exactly. The abdominal wall does not forgive shortcuts.
It really doesn't. Which brings us to the broader perspective of where this field is heading. Looking at the literature, there's a fascinating shift in how we view the operations that actually cause these hernias.
This is a huge point. Consider this. If we understand these biomechanical vectors so intimately now, and we know exactly which patients are at high risk for fascial failure.
The obese, the diabetic, the immunosuppressed.
Right. Are we approaching an era where prophylactic mesh placement becomes the standard of care?
Oh, wow.
Instead of waiting for the abdominal wall to fail after a primary laparotomy, perhaps we should be utilizing lightweight sublay mesh augmentation during the index operation to prevent these massive hernias from ever forming.
Moving from complex reconstruction to targeted prevention. It's a compelling evolution of the exact same principles. We are dynamically managing a living, breathing cylinder.
Exactly.
Well, that is all the time we have for today. If you like this content, please don't forget to share it with at least one of your colleagues or friends to help spread the word and elevate the standard of care.
Yes, please do.
Also, be sure to check out our YouTube channel and other social media pages for visual breakdowns of these anatomical planes. And if you're looking for more clinical insights, do check our previous season and deep dives with some very relevant topics you really won't want to miss. Thanks for joining us in the OR today, and we'll see you next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.